Hello everyone, I am Agnes Wong, a pediatric palliative care nurse from the Hong Kong Children's Hospital. I would like to share a case with you who named MM. He was suffering from a terminal illness and I am his case manager. I facilitate him to go home with the help of transmucosal fentanyl. MM is a 3-year-old boy, was diagnosed with retroperitoneal and boil sarcoma at around 1 year old. He received a full course of treatment, including chemotherapy, gross total tumor resection, and radiotherapy. Then he was disease-free for around 1 year. However, he was noted to have disease relapse at 2.5 years old, and palliative care team was involved. He presented with abdominal distension and poor appetite. CT was done and suggests diffuse tumor metastasis, especially over the peritoneum. MM received further course of chemotherapy with curative intent. However, evaluation imaging showed further disease progression. Oncology team then shifted to another chemo regime for MM. During that period, parents are in distress. They well understood the grim prognosis of their son. They changed the family plan to facilitate MM to enjoy every moment of life. However, they still strive for a chance to cure. Otherwise, they will feel regretted if they didn't try any possible treatment. The family traveled to USA for HIPEC, a surgery which aimed at treating peritoneal cancer. However, it was not done due to multiple bone metastasis was noted on MM before the procedure. Parents told us that the medical team in USA discussed the best benefits of MM with them. They did not suggest for any further surgery. With the balance of the quality of life of MM then received further chemotherapy in USA and then back to Hong Kong. His disease kept on progressing. Oncologists further changed the chemotherapy regime with minimal effect. MM also started to present with various symptoms due to disease progressions. MM complained of dripping of urine and urinary frequency. PET-CT showed disease progression. His mass just posterior to the bladder. Therefore, suprapubic catheter was inserted. He also developed greenish vomits with increased abdominal distension. CT abdomen showed likely mechanical small bowel obstructions and multiple foci of peritoneal metastasis. In view of disease progression, we discussed with family for the direction of care. Parents agree for conservative treatment of IO and not for surgery. They understand the disease progression and would like palliative chemotherapy as symptomatic control if MM can tolerate. We started PCA morphine to control his suprapubic pain. Voice tube was also inserted for decompensation. We also discussed comfort feeding with parents, and they aspirate the gastric content after MM taking his favorite food. We also support the family for limited daily home life with parental nutrition infusion during nighttime. With such support, MM was able to enjoy more outdoor activities and play at home freely in the daytime. MM told us that he wanted to be discharged to go home and play. Palliative chemotherapy was given aiming for symptomatic control and his IO symptom improved. We tried to wean off PCA morphine to fentanyl patch, oral Panadol and morphine, hoping to facilitate home care. However, the pain control of MM is fair. It is noted that MM has on and off suprapubic pain, which is sharp pain in nature and disturbs his activity a lot. It is also noted MM has fair tolerance to oral medication due to his on and off subacute intestinal obstructions, with occasional vomiting after oral medication, which affects his medication absorption via the oral route. With the above consideration, we tried sublingual temgesic. However, the drug is bitter in taste. MM was unwilling to suck and spit them out. A dilemma comes. Shall we resume IV analgesic for better pain control, which would keep MM in the hospital? We know that transmucosal fentanyls can be used for breakthrough episode cancer pain in patients on regular strong opioids. However, it is expensive and there is no transmucosal fentanyl products available in Hong Kong. With experience shared from other countries, we decided to use parenteral formulation of fentanyl as sublingual administration. We discussed the use of sublingual fentanyl with parents and educate them on how to prepare and administer the drug. We firstly calculate the dosage and frequency to be used in breakthrough pain. We then educate parents how to aspirate the required drug from the ampoule and giving the drug into the buccal, mucosal or sublingual. It is important to educate MM not to swallow it and hold it for at least 1 minute. We also educate parents to throw the sharp into the sharp box and monitor the effect. We trial sublingual fentanyl for MM, and here is a video showing that how a 3-year-old boy can take this drug after education.
講多次，呢個似乜嘢味啊？Lollipop。OK， 得啊。
咁食下嗰啲 lollipop。
Under the tongue, OK? Don't swallow. 含住，唔好 swallow 啊。1分鐘到啦。1分鐘含住嚇。你自己傾啦，係啦，用隻手傾啦。
MM shared with us that he thinks the drugs taste good and taste like a lollipop. I think it may be due to the citric content in the drug. He learned not to swallow the drugs and keep the mouth shut till 1 minute passed by, with counting. Overall, the drug effect is well tolerated with satisfactory pain control, which suits MM condition a lot. It has fast onset time within 5 minutes after administration, which is perfect for MM's nature of sharp onset breakthrough pain. Its taste is also well tolerated by children. MM was eventually discharged with fentanyl patch with VLN sublingual fentanyl after drug titration. No IV analgesic was required. While his symptoms were well controlled at home, the family grabbed every moment to enhance the quality of life of MM. They went to Disneyland, Ocean Park, the beach. They let him eat ice cream, play with friends and elder sister. They brought MM back to school and enjoyed the quality time with family members. MM wished to be a fireman when he grew up. With the help from Make-A-Wish, MM has a chance to visit the fire station on his birthday. He enjoyed the day with the firemen, enjoying their daily activity, riding on the fire trunk, and even saved his beloved teddy bear from a small fire. During this period of time, we further discussed with MM parents for the goal of care and further care plan. Funeral arrangement of MM, any preference of legacy making, ways to keep continual bonding with MM were also explored. We also employed parents to discuss die and death issue with MM and his elder sister. Storybooks were suggested and skill and techniques were shared by medical social worker. During the discussion, The parents discovered the care preference of MM and came up with some consensus on the goals of care. When mother talking about afterlife with her children, MM asked his mother, "If I become an angel, I will not have any tubes anymore?" Parents then understood MM really hated the tubes on his body and told us that they did not want MM to undergo any surgery or procedure with tubes, like tapping for ascites or poor effusion or epidural analgesia. Mother said, "Although he is just 3 years old, he is an individual which needs us to respect too." Our focus of care were based on MM and his family's values and belief. The goals of care of MM were set as follows. When MM deteriorates due to the natural progression of disease, which is irreversible, the family not prefer to transfer MM to ICU and refuse respiratory and cardiac support, which may induce suffering to MM. For other decisions like the way to maintain nutrition and fluid and the use of medication, they preferred medical team to keep it if it is clinically required. Although MM is responsive to the palliative chemotherapy, the honeymoon period gradually passed. He required increased dose of analgesic for pain control and underwent suprapubic hypogastric pelvic block twice. The effect of palliative chemotherapy was less effective with time. Disease further progressed, and MM finally needs to readmit to hospital for PCA fentanyl. At this stage, we found that different parties held different points of view on the care plan. The parent team decided to withhold all the chemotherapy and life-sustaining treatment for the best interests of MM, while mother expressed her grievances on the treatment management, as mother wishes for further palliative chemotherapy for symptom control, and stated, "Let's go" is designed by parents, not by medical team. What medical team doing was against her core value, which is trying to do the best. Father perceived MM has already suffered a lot. He hoped for maximum comfort care and worried that further chemotherapy will just prolong MM's suffering. We tried to facilitate three parties to understand each other. Finally, we come up with a care plan with mutual consensus. MM was changed to another palliative chemo with less toxicity and complications. He has partial response to this chemotherapy and was able to tail off all IV analgesic with continued symptom control by fentanyl patch, methadone, bicarbonate, PRN sublingual fentanyl, and oral oxycodone. He was able to be discharged home and celebrate his 4-year-old birthday with his family members and friends. This time, MM enjoyed a few days at home and was admitted to hospital after his birthday as his symptoms worsening with disease progression. Although the time of period of this time is short this time, the family was happy that they did grasp the last moment to enjoy family gathering at home, especially on his birthday. MM was currently receive care in hospital, and his care plans are guided by quality of life as defined by MM and his family. In summary, we shared a story on working with the patient and family through up and down during the disease progress. We also found that the care plans are guided by the quality of life defined by the child and the family. As is noted that Transmucosal fentanyl can be used for breakthrough episode cancer pain in patients on regular strong opioid, and it is happy to know that the use of parenteral formulation fentanyl as sublingual administration is workable for children like MM. This is all of our presentation. Thank you.